Hey, good morning, everyone. Let me know if you can hear me. All right, good morning. We'll get started here in just a couple minutes. Was like a good morning, y'all. Y'all have had a good week so far, ready for the weekend? You don't see the PowerPoint, did I not upload it on online? Let me look here. You know, it's because I didn't. That's my fault. Sorry, guys. Get it up right now. Yeah, sorry, it's been a rough week. All right, the second part is up now. It'll probably take us a week or two to get through because it's kind of like the spiciest one out of the bunch here. So we'll need definitely 1 or 2 hours today. But yeah, so you should be able to see that now. Cool. Well, apparently it's National Bosses Day, so make sure you tell all of your bosses in your life how much they mean to you. So I'm gonna tell my wife that. All right, so it looks like it's 8 o'clock, so let's go ahead and begin. Start recording. All right, so everyone should have access to the PowerPoint. And we're going to start off on talking about hypertension medications. This is going to be the biggest group of new drugs we're going to be talking about probably this semester other than the antibiotics. And this is important because it's going to apply to all of our cardiovascular conditions, so hypertension, CHF, angina, MI, all this kind of stuff. So this is where we're going to get into the nitty gritty of these drugs here. And the first thing we're going to talk about is the diuretics. And so basically, with diuretics, we know they make you urinate, but how do they do that? And essentially, it's affecting the the reabsorption or blocking the reabsorption of both water and salt, right? Generally speaking, if you block the absorption of salt, meaning sodium and chloride predominantly, but we'll look at some other ions as well, that if you block that, then you're going to have more sodium in the renal tubule just due to osmotic pressure and things like that. You're going to draw water into the renal tubule, and then that gets eliminated as urine, okay? So a general caveat is wherever salt goes, water follows, okay? So if you keep that in mind, this will help you out. Now, you have to keep a good balance between these two here. So if you have too much volume on board, meaning too much water, you're going to lead to volume overload. You're going to have pulmonary edema. You're going to have all kinds of bad things happening here as a result of that, which some disease states will make worse, like CHF, for instance. If you have too little volume, this is where you get volume depletion. You don't have anything to fill your tank, so to speak, and you get cardiovascular collapse. So obviously, maintaining the balance here is going to be critical. Now, kidneys, very, very important. We'll talk about nephro issues next semester specifically, but all of these meds here are going to be affecting the kidneys, and they are highly metabolically active. They require a ton of oxygen because they have all these different transporters. They reabsorb things, they secrete things into the renal tubules, and they get a lot of the cardiac output. And so it's important that they regulate their blood flow and oxygen delivery effectively. And there's lots of ways that we can do that. The kidneys have a lot of control over the rest of the body in terms of managing its blood flow and managing volume status and things like that because of this idea called diuretic braking. So if the kidneys detect there's low volume, if they detect there's low salt in the kidneys, they will then activate a series of rebound mechanisms, right? It's all part of homeostasis, all part of this negative feedback loop that they have where they can do things like activating the sympathetic nervous system. They can affect the renin-angiotensin system, which we're going to talk about much more extensively later on. It can affect a whole number of different things here, which we're going to get into, ADH, all kinds of things. So it's important to understand is like if we introduce something like a diuretic into the system, what is the body going to do to compensate for that? Because if it detects it's losing a lot of fluid, it's going to say, hold up, I want to hold on to more fluid because I don't want my blood pressure to collapse because I don't want to make sure that, you know, the kidneys are still getting good blood flow, okay? So looking at the kidneys themselves, most of you are probably familiar with this in terms of, you know, normal physiology or anatomy that you've seen before. This is what we're going to focus on here with the nephron. This is the functional unit of the kidney that we're going to be concerned with today, right? In general, what you're going to see is that there's going to be blood flow coming into the glomerulus. There's going to be an afferent arteriole that carries blood in, and there will be an efferent arteriole that carries blood out, okay? When it goes to the glomerulus, that's where filtration happens, right? There's all these blood vessels there with all these fenestrations, meaning they have holes that things can flow through. So glucose, bicarb, ions, amino acids, all this stuff gets filtered through and will then go through the rest of the nephron, starting with the proximal convoluted tubule, going through the loop of Henle, going through the distal convoluted tubule, finally into the collecting duct, and then they will be eliminated through to the bladder to be eliminated through the urethra, and then that's your pee, right? So we're going to find that your diuretics work at several different places here, and to understand where they're working, how they're working, and what sort of like side effects and other effects you're going to be seeing are critical, right? Because it is quite easy to kill a patient by screwing up their electrolytes, and many of these drugs affect electrolytes. You want to be careful, okay? And so you got to know what the drugs are doing to understand kind of what you're going to be monkeying with when you introduce drugs into the system, okay? So anyway, so seeing here what the general flow of ions and different products here is going to be. Obviously, we're going to be focusing mostly on sodium. It's very important, but we'll also see that our diuretics affect things like potassium, magnesium, calcium, all kinds of things will be affected here. But most of your filtration that occurs is through the glomerulus, obviously, or actually all the filtration that occurs there. And things like glucose, bicarb, as I mentioned, all these things get filtered here. And you filter quite a bit of your blood every single day. Again, you get a lot of blood flow going through the kidneys there. Even though they're relatively small compared to our body weight, they do get quite a lot of flow. And so you clear the plasma roughly 50 to 60 times a day, which is pretty great because it keeps everything nice and clean. Well, what happens in the proximal tubule? Well, this is where you get most of your reabsorption. So things like glucose, amino acids, and whatnot. Most people don't have glucose in their urine because they reabsorb whatever they filter in the glomerulus. However, if you overwork those transporters and they get oversaturated, then that's when you start to pee out glucose. And that's what you can see with diabetic patients, for instance. You also see there's also some secretion transporters, things that will secrete things into the renal tubule. That can affect certain medications, but we'll talk about that on a more case-by-case basis here. But about, half to 2/3 of the filtrate gets reabsorbed here in the proximal convoluted tubule, okay? So there'll be one class of drugs that work here, but these are going to be pretty wimpy drugs that work here because you have the whole rest of this nephron that can basically reabsorb whatever water and salt that it's affecting very early on. So that's going to be a general rule of thumb, is that kind of working later on in the nephron, you're going to get a little bit better utility because you're going to have less nephron to basically be able to compensate for that, as we'll see. So I'll show you a few examples of that later on. The loop of Henle, this is an extremely important piece here. This is where you're going to get the most bang for your buck out of diuretics, is affecting the loop of Henle. You can see that on the descending portion, that it's going to be permeable to water. And then on the ascending portion, we're going to find that there are transporters that will allow for reabsorption of sodium. This is what allows you to concentrate your urine most effectively. So if you're in the desert and you have no access to water, your loops of Henle are extremely important in order to make sure that you are only excreting the most concentrated urine possible and able to hold on to as much fluid as possible, right? Very important here. This is where your loop diuretics are going to work, which makes sense. Loop diuretics, loop of Henle, and that's exactly what they're going to be working at. In the distal convoluted tubule, this is not nearly as important in terms of sodium reabsorption as you would see with the loop of Henle, but this will still be an important target for some of our diuretics here. Only about 5% of the sodium gets reabsorbed here. And we'll see that some degree of effect will come about by aldosterone, which is our main mineralocorticoid that we release in the body. We'll talk about their actions later on. And this is where your thiazide diuretics work. So if you hear about like hydrochlorothiazide or chlorothiazide, these are where these diuretics work here. And then finally, in the collecting duct, you have the last bit of ability to sort of affect how dilute or concentrated your urine is. And this is where things like antidiuretic hormone come into play here. This has a big effect on how much water you're going to reabsorb to either concentrate the urine, or if you have little ADH, this is what it's going to cause you to excrete very dilute urine, right? So that's an important thing here. And if you've ever heard of someone, for instance, drinking alcohol and they break the seal and they have to urinate a whole bunch, that's because alcohol actually decreases ADH secretion, and so they cannot reabsorb all that water, and so they have to urinate a whole bunch, right? So this is where our potassium-sparing diuretics are going to be working at mainly. So let's talk about our diuretics in terms of kind of most beneficial in terms of getting rid of fluid on down to sort of the least effective. And so starting out, we're going to have our loop diuretics here. And so these pictures here will give you a good idea of what's happening within the nephron itself. So here you have the luminal side. This is where you've had the filtrate coming through. This is where the urine is being produced. Here are the renal tubule cells, and then you have the interstitium on this side here. This is where the blood is, right? Remember, there's the vasa recta. It's all those blood vessels that surround the nephron that allow for reabsorption back into the systemic circulation, okay? Basically, we're going to have 4 drugs here called furosemide, bumetanide, torsemide, and then ethacrenic acid. These are your loop diuretics. And so if you need to get rid of fluid off of a patient's body and you don't want to use something like dialysis, this is the best way to do it, okay? What does this do? It will block this transporter here, the sodium, potassium, chloride transporter, okay? It will block the activity of this transporter, so all of this stuff, all these ions stay out here on the luminal side. When you block that, that causes water to go along with it. Water follows all of those ions there. And so by doing that, you're going to have more water in the renal tubules, and then they get eliminated through the collecting duct as urine, okay? So these are very good at getting rid of fluid. Other things you're going to find here too, as a result of disrupting this transporter, you're going to find things like magnesium and calcium will also be eliminated. Okay, so you can already expect to see some of the problems here is that you're going to have issues of losing potassium. You're going to be losing magnesium, calcium. You may lose too much sodium. So again, when you're looking at these diuretics, have a good idea for what sort of electrolyte disturbances they may cause as a result of their actions. So with loops, they're really good at getting rid of water, but you're going to be also losing all these electrolytes as well, which may be an issue for some patients. You can see here, they inhibit sodium reabsorption by about 20 to 25%. So you can increase your urine output like 4 liters a day, which, if you imagine 2-liter bottles of soda, you have 2 of those, that's quite a bit of extra urine you're going to be producing every day, depending on the size of the patient. Again, we're increasing excretion of potassium, calcium, and magnesium, okay? Most patients don't have issues with having too much calcium or magnesium or potassium, but you can definitely cause issues with have too little, and that can also be problematic, as you're going to see. Now, what are some other actions of the diuretics? Well, when the kidneys detect that they're losing too much volume, they don't have enough salt, they will then activate all these reflex mechanisms. They'll activate the sympathetic nervous system. They're going to be activating the renin-angiotensin system, and it's going to have a whole lot of systemic body actions, as we're going to see here. So for instance, you can see that hyperglycemia can be a consequence of the actions of loop diuretics. And you're like, well, why would that affect glucose if it's just working in the kidneys? Well, if I lose potassium, that actually impairs insulin release from the pancreas, right? Or if I'm activating the sympathetic nervous system, I can find that by activating things like alpha-2 receptors, I can decrease insulin release, which causes obviously less insulin, means more blood glucose. Or if I activate beta-2 receptors, that causes glycogenolysis and causes gluconeogenesis from the liver, for instance. And only that can also induce a little bit of insulin resistance. So you can expect blood sugar to go up to some degree. May not be clinically significant in most patients, but if they're diabetic, like some of these patients will be, that's a problem, right? You can also end up seeing some systemic vasodilator actions here. We're going to see that this is going to be more of an issue when you have patients who are taking NSAIDs. We'll get into this a little bit later on, so don't worry too much about this right this second. We're also going to see that the renin-angiotensin system is going to be kicked up here. We're going to talk extensively about that in this lecture, but basically this is going to be a system to produce something called angiotensin 2, which is a very strong vasoconstrictor. And we know what happens when you introduce vasoconstrictors. They cause blood pressure to go up. This is also going to cause aldosterone to increase release and also cause more antidiuretic hormone. Remember, antidiuretic hormone causes you, to excrete less water in the urine, but it also causes salt thirst, essentially. So it causes you to want to drink water and get salt as a result of this increased ADH. So it doesn't just affect the kidneys, but it can affect behavior from the CNS even, right? Other things too is as you decrease blood volume, as you start to concentrate the blood, you can get higher levels of things. And this can include things like uric acid. And not only that, but also these diuretics can cause more reabsorption of uric acid from the proximal convoluted tubule. Okay. So again, it doesn't just work in the loop. You can see other ancillary effects, other downstream effects of these medications here. So if your patient had gout, this may worsen that, right? So you'd want to definitely watch your uric acid levels for them. You can also end up seeing sort of a mild metabolic alkalosis. What I mean by that is by urinating out all this extra water, you concentrate the blood volume. So normally if your bicarb is sitting like, say, between 21 to 20, which is normal, as you get rid of that extra water, it concentrates. So now it may actually go up, which can end up leading to a metabolic alkalosis, which may or may not be clinically significant. You can see some increase in your serum lipids. Again, some of these patients may have dyslipidemia concomitantly with whatever condition they have to need to get rid of this extra water. And you will see there's some issues in terms of the kidneys with the macula-densin affecting angiotensin 2 and GFR and all of that. I'll talk more about that in just a little bit. So ultimately, though, what we can also see is that loop diuretics are great because they remain effective even if you have patients with really poor kidney function. Think about normal kidney function being somewhere like in 80 to 100 or somewhere like that. Some diuretics tend to lose efficacy as renal function goes down. What you're going to see with this is that even if they have creatinine clearances below 30, which is significantly decreased, they will still retain effectiveness. They will still be able to cause increased urine outflow. Okay. So what do we use this for? Typically, we're not going to use loop diuretics for hypertension specifically. Because of all those reflex mechanisms, you tend to find that it may be effective really early on, but it tends to lose that efficacy. You're going to find that the blood pressure may go down for a little bit, but then it picks right back up because of things like the renin-angiotensin system and all of that. But if you want to get rid of fluid, loop diuretics cannot be beat. So pulmonary edema, extra fluid on the lungs. If they have nephrotic syndrome, they can't correctly affect their water balance because they are missing serum proteins. If they have cirrhosis, that these big old bellies just full of fluid because of their liver dysfunction. If they have heart failure, if they have renal failure, and again, if they have hypertension related to extra blood volume, then this may be helpful, but not for chronic hypertension, as we're going to see here in just a little bit. But basically, you got to get rid of fluid. Loops are your friends here. Now, again, we've already talked about a lot of these adverse effects, and you're going to see that a lot of these will actually apply to other diuretics as well. So if you can have this in mind in terms of general adverse effects for diuretics, it can be helpful. I'll point at the ones that are more specific to the loop. So obviously volume depletion, right? Low blood pressure, tachycardia, can certainly expect to see that. You can develop hypokalemia, which can aggravate arrhythmias, right? You can cause this contraction alkalosis, this hyperglycemia, hyperuricemia. Something a little more unique to the loop, so actually is ototoxicity. It can actually damage hair cells in the cochlea and can lead to some non-reversible hearing damage, just like with something like a aminoglycoside, for instance, right? Some patients will have an allergic reaction to these. This is more related to if they have like a sulfonamide allergy. Some of them will cause a cross-reactivity. You tend to not have that, though, with the drug ethacrynic acid. So if I had someone who had a true furosemide allergy, you could utilize something like ethacrynic acid, and that would be relatively safe. Okay, so you don't want to like lose all your loop diuretics there. So that's one of the benefits of ethacrynic acid. You can do that. If anyone's ever curious where the name Lasix comes from, Lasix for furosemide, it lasts about 6 hours. So Lasix, so that's kind of where they got the name from. So, you know, a little bit of esoteric drug information for your curiosity. We're going to see there's a lot of interactions with other medications, though. For instance, like NSAIDs tend to blunt the natriuretic, which just means sodium urinating abilities and blood pressure response to your diuretics. And so this is something I want to illustrate for you here. I want to draw it out. I probably have illustrated this before, but it stands to draw it again just in case you don't remember all of my lovely art skills here. But basically, if you imagine, you know, the glomerulus of the nephron here, we're going to imagine we have our afferent arteriole coming into the nephron, our Bowman's capsule here, and then we're going to have our beginning of our proximal convoluted tubule. And so basically, we're going to have blood flow coming in this direction, and you're going to have blood flow coming out of this direction, and then you have filtration happening in this direction, and I make this yellow because this is your urine. So sorry if that contrast there is hard to see. So again, this is the glomerulus. This is where the actual filtration happens, right? Well, what would happen if I were to, say, do something like introduce a NSAID into the system here? Well, you have to think about what's happening with these afferent and efferent arterioles. We're going to come back to this a little bit later on with another class of drugs. But if you imagine if I were to do something that introduces a drug that would pinch down and cause this vessel to constrict, what would happen to the filtration that happens here? Well, what happens if you pinch off a garden hose? Well, the flow kind of stops. And so this is similar to what happens here. If I introduce something like an NSAID, you're going to find that you're going to decrease prostaglandin production. Now, what do prostaglandins normally do? Well, prostaglandins cause vasodilation here. And if I introduce an NSAID that decreases prostaglandin synthesis, you're going to cause ultimately constriction of these vessels here. So giving an NSAID will cause a constriction of this vessel, which will decrease urine production, GFR, that glomerular filtration rate, and that's going to cause a decrease in kidney function. So that is important for patients who especially are reliant on these prostaglandins in order to keep those afferent arterioles open, okay? What that means, though, for people taking diuretics is that it can limit its effectiveness, because if you have less filtration happening, then you're going to have less water for the actual drugs to work on in the kidneys, in the tubules. So that's one way we're going to see a big interaction here. So that's why if you ever hear someone taking an NSAID causing renal failure, this is the mechanism for what's happening here. They were dependent on those prostaglandins, and now they're gone. Okay. Also, this is what makes some of your diuretics less effective, is by decreasing the amount of blood coming in to be filtered in the first place. Okay. That doesn't make sense. Let me know. Other things too, right? So if you combine it with other drugs that can potentiate its toxicity, PowerPoint. You know, like aminoglycosides. If I had someone in the ICU who's on aminoglycosides for a pseudomonal infection, and then they also need to be on a loop diuretic for a volume overload, that can potentiate the ototoxicity. So you got to watch out for that sort of thing there, right? You can cause a lot of other effects as well. Things like lithium. Lithium is something we use for bipolar disorder we'll learn about next semester. You can actually cause accumulation, which can lead to some pretty significant CNS toxicity. Or antiarrhythmic medication, things that work to treat heart arrhythmias. It can cause hypokalemia and hypomagnesemia, and this worsens the risk for arrhythmias. So again, all these things you want to watch out for. Got to watch electrolytes if you're going to be giving patients diuretics, right? Either in the acute phase in the hospital or for the chronic phase, okay? Moving on. Next, we have our thiazide diuretics here. And so we have the specific thiazides like chlorothiazide, hydrochlorothiazide, or if you ever hear HCTZ, this is what they're referring to. I had one patient come up to when I was interning at a Publix pharmacy when I was in school. Someone came up and they said, "Oh, I want a refill of my Huctaz." I was like, "Huctaz, what the heck is that?" And then I had to figure out he meant HCTZ. But we also have thiazide-like diuretics, which includes chlorthalidone, metolazone, and then indapamide. Okay. Again, if you know all 5 of these are thiazides, you're good to go, right? I don't care if you know which ones are really thiazides or which ones are thiazide-like. Just know they're all thiazides. Okay. What these are going to do are going to work in the distal convoluted tubule, right? So you've got to know where these drugs are working at to know how they're going to be, what kind of actions they're going to have here, okay? So you got to know loop diuretics work in the loop, or in the loop of Henle. That makes pretty good sense, but knowing that thiazides work in the distal convoluted tubule is another more difficult association because it's not in the name, right? But what you can see here is, again, same diagram. We're just dealing with renal cells in the distal convoluted tubule. Basically, there's a sodium chloride transporter. Now, back in the loop is a sodium potassium chloride. Here's just sodium chloride. So basically, the thiazide diuretics will inhibit this transporter here and will cause more sodium chloride to accumulate on the outside in the renal, in the tubule, and that will then be eliminated along with more water, right? So you're also going to see some other mild effects here. We'll talk about carbonic anhydrase a little bit later. If you recall talking about glaucoma, you should know what this enzyme does, but we'll reiterate that in a few moments. And then it also can act as a phosphodiesterase inhibitor. This is going to be handy for its anti-hypertensive effects here, as we'll see in a little bit. So I'll come back to that in just a few moments. Other things you're going to see too is that by blocking this transporter here, and you have less sodium within the cell, you're going to find that this ATPase pump is going to be working less effectively because there's less sodium for it to actually shuttle out of that cell. And what that means is because we have less sodium within the cell here, it's going to be dragging in more sodium from the outside. And this is going to cause more calcium to be reabsorbed. So what's interesting is whereas with a loop diuretic you lost calcium, this is actually one class of diuretics where you actually can hold on to more calcium, which means you can actually see hypercalcemia in some patients, okay? One important distinction here. And again, I want you to know which electrolytes are going to be lost or retained with these different diuretics, especially when it comes to things like calcium and potassium. Those are the 2 big ones I want you to know because otherwise, yeah, they all get rid of sodium. You're all going to get rid of magnesium to some degree. But what's it holding on to with certain classes of diuretics, that's a good thing to know, okay? But anyway, so you're going to find that thiazide diuretics in terms of their efficacy in just getting rid of fluid are less effective than something like a loop diuretic. But we're going to see they actually get used probably more frequently overall because they have some other ancillary benefits that we'll see here in just a little bit. So you'll see increasing your output maybe like 1 to 2 liters per day as opposed to like 4 like you saw with the loop diuretics. We'll see some more potassium, magnesium excretion, but we'll see decreased renal calcium excretion. You're going to hold on to more calcium, which can actually cause hypercalcemia to some degree. Usually pretty mild, but you can see that, okay? Other effects we're going to see here, and this is actually just like we saw with the loops. You can see hyperglycemia. You can see uric acid because the contraction part of losing that fluid, the reflex part of activating the sympathetic nervous system, these are all the same, right? These have all been things we've seen with the loops. And acutely, they can increase GFR, so you do want to watch out for that, especially if they have low blood volume already, okay? What do we use these drugs for? Well, we use it for hypertension, for renal failure, for cirrhosis. A lot of similar indications here, but the big thing is for hypertension, you may see. And then occasionally we can actually use this for hypercalcemia or renal calcium stones. And you're like, well, wait a second, you just told me these drugs can cause hypercalcemia. And yes, I will elaborate on that in just a little bit, but this is actually an important point here. So this works really well for hypertension. In fact, for many patients, this is going to be a go-to med for many patients here. And actually, just to address one question I saw on the sticky board, someone said, "Is Bumex stronger than Lasix, or is there any difference?" One is more potent than the other. Bumex, you'll have to use a smaller dose in order to get the same effect as Lasix. So clinically, there's no big difference between the two. You may find some providers like one versus the other. It just depends. But no, either one of those will work equally as well as the other. So no difference there in terms of clinical efficacy. It's just the dose is very different. Okay, so looking at thiazides and their use for hypertension, this is great because they work well in elderly patients, they work well in obese patients, they work well in black patients and those that are in sodium retentive states, okay? And so you're like, well, you know, loop diuretics got rid of more fluid, but they're worse antihypertensive medications than thiazide. So what's the difference with the thiazide, right? A couple of things. And it has to do with their chronic effects. Like, sure, you get some decrease in blood volume and cardiac output in the short term, but that is quickly negated by those reflex mechanisms like the sympathetic nervous system, like the renin-angiotensin system here. But what you're also going to see is, one, due to its ability to affect things like phosphodiesterase, it actually causes relaxation of the arterial smooth muscle. It also gets rid of this water logging effect here. And so I'll show you an example of that. If I were to then paint this out, if you were to imagine a blood vessel, right? So imagine you have this blood vessel, and then you have here, you have the actual cells of that blood vessel. Okay. I draw as neat of circles I can without using the tools there. So what happens with patients who are chronically salt overloaded? Say you eat, you know, a bunch of KFC every day for breakfast, and then you have some McDonald's for lunch, and then you have Wendy's for dinner. Whatever, you're getting a big salt intake all day long, every day. Like some patients' diets happen to be. I don't know who eats KFC for breakfast, but I imagine there might be some, right? Anyway, point being is that when you have a lot of salt in your diet, I'll use red for salt here, you're going to see that the salt tends to accumulate in these walls here. So what happens when you have all this extra salt? Well, water wants to follow it. And so what happens is you end up seeing that there is going to be a thickening of these walls. You're going to see this actually going to become more thick, going to become thicker, and now your new wall diameter is going to look something like this, perhaps. This is probably more dramatic than it is. So what happens when your actual diameter of this vessel gets smaller? Well, that means that blood has less room to flow through, which means pressure is going to go up. So this means that you're going to find that patients who have this kind of chronically waterlogged vessels are much thicker, and they're going to have higher pressure because, again, there's just less diameter there, right? Pressure is going to go because you have the same amount of blood, the amount of volume, but it's just going to go through a much smaller tube, a much smaller hose, so to speak. So by giving a diuretic, by giving something like a thiazide diuretic, which really helps out with this waterlogging effect, and again, this is something more seen with thiazides, you're not really going to see this with a loop, right? With the thiazides, you end up losing this waterlogging effect here because you're getting rid of all this extra salt. And what you find is now the vessel is more relaxed. It has a larger diameter, blood can flow through more easily, and thus you have lower blood pressure. That's why we like thiazides for hypertension and why it's used for a lot of patients as first-line therapy, okay? And again, let me know if that doesn't make sense. So that's a big thing there, is a decreased wall thickness, increased diameter. This is a chronic effect you're going to see. And even with like 25-50 of hydrochlorothiazide, you can get this effect chronically. So really not a huge dose of medication. So you get relatively few adverse effects, especially compared to the kind of high potency of the loop diuretics. And so this makes it a great first step for patients. Yeah, they may notice a little bit of, increase in urine output, but again, this is going to be a short-term effect that they will overcome, and then they get the chronic antihypertensive effects, which is great. David's asking, does this compromise the blood vessel wall? Not really compromise it necessarily. Again, the body has its own protection mechanisms put in place. So again, this is all relative. My pictures are obviously not drawn to scale, nor are they probably a completely accurate depiction, but they at least get the point across, I think. The wall stays intact for sure. So again, we talked about some of those reflex mechanisms like the increase in renin-angiotensin system. This is why thiazide diuretics may not be sufficient by themselves for hypertension for a lot of patients, but they're useful as either first line or as an add-on to something else. And so we're going to see that by mixing this with a mechanism or a different mechanism like blocking the renin-angiotensin system, they're going to have much better synergy. And so synergy is really the name of the game because a lot of patients require 2-3 medications to manage their blood pressure here. Okay. You can also see some hypokalemia. You can see a little bit of mild metabolic acidosis. These effects are less so than what you see with the loops, right? Because they're less potent diuretics, so you get less potent reflex mechanisms kicking in, okay? So that's the one thing I want you to know, the difference between loops and thiazides. These are overall less potent, okay? Talked about the hypercalcemia. And so one of the things I was noting before, I don't know if I mentioned this later. is, yeah, this can cause hypercalcemia, but I talked about it earlier as being used to treat stones, right? I usually talk about calcium oxalate stones or nephrolithiasis, kidney stones. So this is an interesting thing. You'll see this a lot in Florida, especially for patients who don't live in Florida and they then travel here. Our water, especially if you drink tap water, if you live out in the sticks like I did growing up, you drink well water, right? So we drink water straight from a well. It doesn't come from the city. I know some of this for you, it may sound kind of like kind of developing country you're coming from, but yeah, some people still drink well water, and so especially if you get out in more rural areas. Point being is that a lot of that water still has a high amount of calcium, especially here in Florida. And so that can predispose some patients to developing kidney stones, right? And so again, what is a kidney stone? But it's basically calcium that is getting into the renal tubule or getting into the collecting system, and then it precipitates out, right? It comes out of solution based on the concentration or based on the pH, and that causes these stones to form, okay? Well, how can I prevent that from happening? Well, I can give someone a thiazide diuretic, and that can actually help to reabsorb some of that calcium out of the renal tubules and keep those concentrations low enough so that way the stone never precipitates out, okay? And you're like, well, wait a second, like, doesn't that just worsen the hypercalcemia? It may to some degree, but it's usually not going to be so severe, right? Hypercalcemia is much better tolerated than someone with hyperkalemia. And again, mild hypercalcemia is likely going to be asymptomatic in many patients. So if you have someone who has recurrent kidney stones and it's possible to use a thiazide to try to prevent those stones from happening again, you would just monitor the calcium levels to make sure they don't get too high. So since thiazide are less potent, we would dose at higher intervals. So remember that your dose that you're giving in terms of milligrams versus your interval of dosing, so the frequency, are two separate things, right? Remember, the interval is going to be based more so on the half-life of the drug and how long it works for. The dose itself is going to be based on the potency of it, right? So with something like a thiazide, I can give HCTZ one time a day, twice a day, and it works. So it works all day long, and generally most patients will get it one time a day, and it's fine. For something like Lasix, which even though it's a more potent diuretic, I'm going to get more urine output out of that, it's a relatively shorter half-life. Most patients have to take that at least twice a day, if not 3 to 4 times a day. Like I said, it only lasts 6 hours. There's 24 hours in a day. So the frequency is going to be dependent on the individual agent and how long it works for, essentially. But it's a good question. Okay, some other things, you might see some photosensitivity. So again, make sure they're watching the sun exposed areas if they're out there in the sun. And again, if you see things like dizziness, headaches, and weakness, that typically is a result of lower blood volume, right? Less blood volume means you're getting less blood flow to the head, which can lead to that. So any of these diuretics can do that as well. Sexual dysfunction is also pretty typical with a lot of these diuretics. Imagine if your body is in a state where it's trying to hold on to blood volume because it's trying to perfuse the more critical organs. Sex organs aren't really all that critical in the grand scheme of things in order to keep that patient alive. So it's possible you're going to see patients may complain about new sexual difficulties and may not be able to achieve an erection, for instance. That's a pretty common thing you're going to see with a lot of antihypertensive medications. Some are better than others, and I'll point those out when we see them, okay? And again, that's a common reason for patients to discontinue use, because patients with hypertension, they don't feel hypertensive typically unless they have really severe hypertension. And so if you give them a medication, say, here, this is going to help you live for longer, but they just feel worse taking it. They have a side effect like this where they can cause some, some relationship distress. They're not going to like that, right? And so this is a common reason for patients to stop taking it. So other things too, because of the extra calcium on board, you can see constipation as being another side effect here. You want to watch out for that. And then as opposed to the loop diuretics where they retained efficacy even in very low GFRs, you're going to see thiazides tend to be ineffective at low creatinine clearances. So once you get down below 30 to 40 mLs a minute, thiazides tend not to work all that well. There's one exception to that, and that's going to be metolazone, and this is one that retains efficacy even at very low clearance rates. That's one good thing to know. Patients with really poor kidney function, less than 30, you want to use metolazone as opposed to any other thiazide, okay? Loops, you can use them all day long for anyone. Doesn't matter what their creatinine clearance is. And again, just like we talked about with drug interactions, NSAIDs are going to be a big one, like we mentioned before. Same exact reasons why as loops, and then increased risk for issues with digoxin toxicity, because again, you can be losing potassium, just like you did with the loops, probably to a lesser degree. But again, this can aggravate arrhythmia. So you got to watch your electrolytes. You want to get a baseline, basic metabolic panel, and then you can follow up with that later on, right? I know everyone, whenever they say, what labs do you want to order? I'll get a CMP and a CBC, right? You don't always need a CMP, right? You don't always need liver function tests. It depends on the meds they're taking and other factors. But at least a BMP, you can at least get a decent idea of the basic, basic electrolytes on there. That's why it's a basic metabolic panel, right? All right, moving on. Next, we have our potassium-sparing diuretics. This kind of tells you exactly what they're going to do right in the name here. So there's going to be two varieties here we're going to see in just a little bit. Some of these are going to be working slightly in the distal convoluted tubule, but for our purposes, you can mainly think about them working in the collecting duct. This is the main place we're seeing here. So loops worked in the loop of Henle. We then saw the thiazides are going to be working in the distal convoluted tubule, and then now we're at the collecting duct. Notice we skipped over the proximal convoluted tubule. That there's a reason for that, and it's because we're going a decreasing level of potency of diuresis. And so we're seeing here the collecting duct is going to be not the best spot to actually get rid of a lot of extra fluid, right? Loops are still going to be the most potent out of the bunch here. So what we have here is basically you're going to have with our specific potassium-sparing diuretics, they're going to be blocking this luminal sodium channel. So they're blocking this channel right here and preventing sodium reabsorption, which means you're going to get sodium trapped out here in the lumen, and that can be eliminated in the urine, okay? And it will draw some water along with that. You're also going to see overall this inhibition of a couple different antiporters here, which can affect flow of different ions like calcium and hydrogen, as we're going to see in a little bit. And I'll talk about the clinical significance of that in a moment here. Now notice it really does not do a great job of inhibiting sodium chloride reabsorption. It's pretty wimpy overall, right? So you're not going to get a ton of extra urine flow out of this. However, though, what we are going to see is that they are potassium sparing. So you're like, well, why is that? Well, basically, if you have more sodium being absorbed here, this causes more potassium to be excreted here, right? So it's a seesaw sort of effect that you see. And so basically, by blocking the sodium reabsorption, you then cause less potassium to be excreted here. So that's why they're potassium sparing, because you end up holding on to more potassium. So what's useful about these drugs is they can be used to offset the hypokalemia from other diuretics. I can add this onto a thiazide and mitigate some of the potassium loss effects I'm going to see from thiazides by using a potassium-sparing diuretic, okay? So again, you got to know, especially with potassium, potassium is so important because there's no easier way to kill a patient than to screw up their potassium, especially on the high end of things. So you've got to know which drugs are going to be affecting potassium, know if it's going to decrease it or increase it, okay? Obviously, I'm making a big point about this, so you probably should be like underlining this on your notes or triple starring it or something, because there's probably going to be some questions on the test about what's going to happen with potassium if you introduce a certain kind of drug. And again, there's a lot of drugs that can do this, so let's make note of those. Anyway, so again, typically you only get a very modest increase in urine flow. Typically these are added onto other diuretics to try to hold on to some of that potassium they would lose otherwise, which makes sense because like with the thiazide, you're losing that potassium in the distal convoluted tubule. Here, we're now in the collecting duct, we can just pick it back up, right? That way we can try to compensate for that and try to hold on to what we can. We have two drugs here, and these are not used frequently, but there's amiloride and triamterene. Often these are only going to be found in combination with things like hydrochlorothiazide, usually used for hypertension. Again, their antihypertensive effects are pretty wimpy, but they help out with not getting rid of all that potassium for those patients on HCTZ, for instance. So we're going to see the same indications as others, similar side effects, the only difference being the potassium retention sort of effects you're going to see there. And again, rarely are they ever used by themselves, at least those two that I mentioned. Hyperkalemia, this is where you got to be careful, especially if patients are taking potassium supplements, if they have poor kidney function, which causes them to retain potassium anyway, or if they're on other medications that increase potassium, such as the ACE inhibitors and angiotensin blockers. We're going to look at those later on when we get into the RAS system, okay? Some rare things you can see that are unique to these drugs. You can see like a megaloblastic anemia with triamterene and then azotemia with amiloride. Those are kind of unique to those specific drugs. Now, another way we could also try to hold on to potassium in the collecting duct is with aldosterone. And so some people will lump in aldosterone antagonist into the group of potassium-sparing diuretics. So they kind of have a little bit of similar action, although the mechanism is different. Now, what does aldosterone do normally? I talked about aldosterone being a mineralocorticoid. Think mineral, you think salt. So we know that's going to be affecting salt. We know it's going to be affecting fluid as well, right? Because wherever salt goes, water wants to follow. And so basically aldosterone is a hormone that's going to be interacting with the nucleus of these cells here. It's going to be causing actual production of these numbers of sodium transporters. So more aldosterone means more transcription of these proteins here and translation into producing these transporters right here that absorb sodium. So by blocking this, blocking those receptors there, you're going to have less sodium transporters, and thus you're going to have less sodium being reabsorbed here, and that also means you're going to be holding on to more potassium. Okay. You'll see a little bit of increased activity in the distal convoluted tubule as well, but I mainly just focus on the fact that it's working in the collecting duct here. Okay. So we have two drugs that block aldosterone. We have a spironolactone and then a pleuronone. And so we're going to see they have a little bit different usage here. Spironolactone is probably going to be the most common, and we mentioned that already in derm a little bit earlier there. But again, this is going to be most effective when you have patients who have a high aldosterone levels already, because again, they're going to have the most to lose if you end up blocking those receptors there. They take a little bit of time to kick in here. You're going to see they have very modest effect in terms of sodium chloride reabsorption. So again, not a ton of increase in water loss, but they will decrease that potassium loss you're going to see there. Hold on to more potassium. And in fact, what's interesting, if you have patients who have hyperaldosteronism, Addison's disease, they actually end up losing a ton of potassium all the time because they have too much aldosterone activity, right? So again, you can see if we block that, you actually end up holding on to potassium, which is handy. Again, a little bit of calcium excretion, but that's going to be minimal effect. So what do we use these for? Well, if they have primary aldosteronism, that could be one thing. So they're secreting too much from the adrenal glands. With hypertension, this is typically an add-on medication, we'll see, to help out with the potassium loss from other diuretics. And then for CHF, so this is actually interesting. We'll get into this later, but this actually does have some mortality benefits for those patients there, as we'll see later on there. And again, you can use it for some edematous conditions as well. In terms of adverse effects, we see that hyperkalemia is going to be one of the main things you're going to see there, right? So I'm going to bold that because that's exactly what you'd expect. Because again, you're holding on to more of that potassium there. And then this is another unique thing of the class here where it's going to have weak androgenic effects. So because it's a hormone, because it's shares a similar structure to things like testosterone, you're going to see that it can interact with those receptors to some degree, okay? Which means it has a partial androgenic activity, partial agonist at those receptors there. So what does that mean? Well, it basically means that depending on where your patient's initial sort of set point is for testosterone, overall testosterone activity, you can find that it will have masculinizing effects in females or women or people who have high estrogen levels and relatively low testosterone activity. And for people who have relatively high testosterone activity, it's going to then drop them down. And so to kind of show you what I'm talking about, and again, from a pictorial sort of standpoint, I'm doing all kinds of drawing today. My correct window up. So let's say we're imagining we are looking at testosterone activity in patients. Second line. So let's say you have two different patients here. You have one patient. Let's see, we're going to have T activity here on the y-axis. So T meaning testosterone. So the higher the bar, the more testosterone activity you have, right? So let's say we have two patients here. We have one who has a normally high level of testosterone activity, and then we have another patient who has, oops, that should be orange. And then we have another patient who has relatively low testosterone activity, right? This may be a female here in the purple. It may be a male in the orange, but again, you may have patients who are outside of the norms in terms of the levels there, right? You may have a transgender patient, who knows, right? So anyway, point being is that if I introduce something like a partial androgen agonist, right? So something that's going to be only partially agonizing those receptors, their overall activity is actually going to be going down. So for the patients here with high testosterone activity, the addition of something like spironolactone can actually cause overall testosterone activity to drop down to maybe something like this, right? So now their actual activity is probably something lower down here, right? So now we've kind of lowered that. For someone who has low overall activity of testosterone, you introduce something like spironolactone, you can actually end up seeing an increase in activity, right? Because now those receptors are being more heavily hit. And so now what we can end up seeing here is we're going to find that the overall activity is actually increased, right? So now they're up here. So what does that mean? Well, for people who have high activity of testosterone beginning to start with, their overall activity is going to go down. You see here, and for people who have low levels of testosterone activity, it's actually going to go up. Okay, so typically what that means is that for like male patients, you can end up seeing feminizing effects. They can have gynecomastia or development of the breast. For female patients, you can see hirsutism, maybe slightly lowering of the voice, things like that. So again, it seems counterintuitive, like why it would cause both in those patients, but you have to think about what they're resting testosterone activity is, and whether spironolactone is going to increase that overall activity or decrease it, depending on what their resting state is at. And hopefully that graph is an okay way to demonstrate that. I'm not sure. You can let me know in my evals as well, or on the sticky board perhaps, saying that made no sense. What are you talking about? But I think it's an important point because, again, that could be another reason why you'd stop taking the medication. If you're like, wow, I'm noticing it looks like my testicles are shrinking. Like, what's going on here? I shouldn't be taking this medication. You let them know that it could be a possibility. Let them know that, right? Or if they're trying to get pregnant, trying to get their partner pregnant, that may be a difficulty, right? Because it may see some decrease in fertility because they have this overall less androgenic activity and they're producing less sperm, for instance. Just depends on the patient, right? These are things you want to note. All right. And then moving into our carbonic anhydrase inhibitors, these do exactly what they say. They inhibit carbonic anhydrase. And we've already covered some of these in the glaucoma section. We talked about things like brinzolamide and dorzolamide. These do the same things. They're just mainly working in the proximal convoluted tubule. These are the wimpiest of the diuretics. And again, they don't get used frequently for this purpose here to get rid of fluid. Because if you think about it, if I decrease fluid reabsorption in the proximal convoluted tubule, well, I still have to go through the loop, which I know can absorb a lot of water. I still have to go through the distal and the collecting duct, which can also reabsorb water. So overall, they really have minimal effects here, especially in the long-term effects. So, but we have some other uses for them, as we'll see here in just a little bit. But basically, they're blocking reabsorption of bicarb. Okay. We have 3 drugs here. We have acetazolamide, chlorphenamide, and then methazolamide. Acetazolamide is probably the most common one you're going to run into out of the bunch here. So let's look at what they're doing. Again, we have the proximal tubules. On either side, we have the one where it's normal, and then we have the one where we introduce the carbonic anhydrase inhibitor. And again, notice the proximal tubules. These are complicated because they reabsorb so many things right there at the very beginning of the nephron. But essentially what you see is that normally when bicarb gets filtered through the glomerulus, it's sitting out here in the renal tubule. Bicarb itself cannot be reabsorbed. It's not permeable to these cells here. What is permeable, though, is CO2 and water. So carbonic anhydrase will then break it down into CO2, carbon dioxide, and water, which is much more permeable. It'll get reabsorbed, and then carbonic anhydrase can then reassemble it back into bicarb and can then be reabsorbed, right? Notice here you have some loss of hydrogen ions, which can lead to some of the acidification of the urine, right? Think about normal urine pH of being something like 5.5 to 7. It can range quite greatly because the kidneys are so important for regulating pH of the body. But what happens if you introduce a carbonic anhydrase inhibitor like acetazolamide? Well, you block this enzyme here, so all this bicarb still stays on the renal tubule side, and you just pee it out, right? Because there's really nowhere else in the renal tubules where you reabsorb bicarb. So because of that, you can actually end up seeing an alkalizing of the urine. More bicarb in the urine is going to increase the pH. But also, what happens if you lose that bicarb from the body? Well, probably causes an acidification, right? So you can actually see a metabolic acidosis from utilization of these drugs here. Okay, it's mild, but you can still see it. And so that's an important distinction there because not really any other drugs we've seen has caused a metabolic acidosis before. Okay. Again, we talked about their use in glaucoma, but some other typical uses you're going to see include things like epilepsy, typically by causing a metabolic acidosis that can increase the seizure threshold for patients, making it more difficult for them to have a seizure. Maybe good for them. Same reason why they use ketogenic diets, because it puts the patient into a more acidic pH. They can also use it for mountain sickness, right? And what is mountain sickness? I've lived in Florida all my life. I don't know what a mountain looks like. I'm just kidding. I have traveled outside of the state. But what happens when you go up to, let's say if I go from here, I've done this a few times actually. There's conferences, it'll be in Denver, Colorado. Every time I think, oh great, I'm going to have huge headaches, right? Because when you're going from sea level or maybe even below sea level, since we live in a swamp here in Florida, up to a mile-high city, the partial pressure of oxygen decreases pretty significantly, right? Just because you're higher up in the atmosphere, less oxygen. That means that your body is no longer equipped to handle the oxygen pressure that's out there. So if you've never done this before, I implore you, if you go to Peru and go to Machu Picchu, if you go to, you'll actually find you try to climb up a set of stairs, and you're going to get winded so quickly, and you're like, what is going on here? Like, I know I can walk up a set of stairs, but you're going to feel so winded because your body's not used to being able to handle that low partial pressure. What's interesting here is you can actually take something like acetazolamide, and that actually induces a metabolic acidosis, right? What's that going to do for your oxygen levels? Well, metabolic acidosis causes your body to want to breathe off that extra CO2, and so it's going to cause a mild tachypnea. So by breathing faster, you're actually going to be bringing more oxygen, and that can then help to ameliorate some of those side effects of mountain sickness, like headaches and fatigue and things like that, while your body takes time to do things like increase hemoglobin levels and things like that. So that's a thing you may see that being used, especially if patients are going up to like really high altitudes very quickly. They may utilize acetazolamide. You also see that these drugs can also decrease production of things like CSF, fluid. I guess it doesn't make sense to say CSF fluid because it's cerebral spinal fluid, but CSF. Basically, by decreasing that, you can actually decrease patients who are having cerebral swelling. So if you have like a traumatic brain injury, or if you have a hydrocephaly or something like that, it can actually decrease production of fluid, and that can decrease swelling, which is good because brain swelling is not great because you have this big thick skull in the way, and so there's only one place for brain matter to go when you start to herniate, and it's out the bottom, and that's not great. So, as I mentioned, adverse effects of metabolic acidosis. This is the only drugs we've seen so far in this lecture that causes metabolic acidosis. All the other ones cause a contraction alkalosis, so that is a unique thing you're going to see with that. It can also cause potassium depletion to some degree, and then maybe some drowsiness as a result of some of the CNS effects. So those are the diuretics, right? It only took me a solid 50 minutes to get through. But again, know what they're doing. Know which ones hold on to potassium, know which ones lose potassium, which ones get rid of calcium, which ones hold on to calcium, which one causes metabolic acidosis versus metabolic alkalosis, right? These are the distinctions you want to be able to make between the different classes, okay? To be able to know if I ask on a test question, patients start a new medication, a new diuretic, and their potassium comes in, and it's 5.5, and a normal is 3.5 to 5. What could cause that, right? Obviously, that's hyperkalemia, so you only have a limited set of drugs that can do that. Those are the things we're going to be looking for, right? Moving on. Now we have our renin-angiotensin system inhibitors here. So we're going to have to describe what the renin-angiotensin system is. And some of you may already know what this is, or you've covered it in other classes. But if not, I'll give you the brief overview. So a renin-angiotensin system is extremely important, has whole system-wide effects in terms of regulating blood pressure. To that end, it also can affect things like secretion of aldosterone. It's going to be affecting renal blood flow. It can affect sodium excretion. It has CNS effects like affecting ADH. It can have effects on the autonomic nervous system, specifically like the sympathetic nervous system. So it kind of does a little bit of everything. And so this is why it's so powerful to, if I can block this system, you're going to see really big effects here in terms of affecting patients' blood pressure and all of that. There's going to be some other really good ancillary effects to these drugs as well. So what happens here? Well, if the kidneys are in a state where they say, oh, wait, there's not enough pressure here, I don't have enough salt here, it's going to activate the release of renin. So you can see here, kidneys release renin. Renin is going to help produce something called angiotensin 1, which is produced from angiotensinogen. And then angiotensin 1 gets converted to angiotensin 2 via ACE, angiotensin converting enzyme. What are the important things you need to know? Kidneys produce renin when they detect low pressure or low salt. And then that ultimately ends up producing angiotensin 2, which is made from ACE. Okay? Those are the two biggest steps I want you to know there. I don't care if you know angiotensinogen forms angiotensin 1. I want you to know that ACE forms angiotensin 2, and that the kidneys release renin. That's the important part. Once you have that there, angiotensin 2 causes vasoconstriction of the arterioles, so it squeezes down those vessels, increasing pressure directly. And it also increases release of aldosterone, meaning you're going to find more salt retention in the kidneys. You're going to be losing potassium, and it also can lead to higher pressure. So not only do you have more blood volume because you're holding on to more fluid, you're also having more constriction on the vessels. This is why these are very potent vasoconstrictors, very potent in increasing blood pressure, okay? And it's the mechanism for a lot of patients' hypertension, which is why these are so effective and used in a lot of patients. The other thing, too, this is going to be important for some of the clinical effects, but more so the side effects of the meds, is that ACE also breaks down a product called bradykinin. Bradykinin is something that naturally is a bit of a vasodilator, so this can actually help out. If I block the breakdown of bradykinin, it can be useful for some vasodilation, but also accumulation of bradykinin can lead to some side effects we're going to see here in just a little bit, okay? So also, so looking at this, you can see the rate of release of renin from the kidney is not only due to the macula densa, but also the renal baroreceptors, right? They detect pressure, right? So if they have low pressure, they say, whoa, we need to increase this. And so this is why the renin-angiotensin system gets activated. It's why they release renin. So you can see also the sympathetic nervous system can play a role here as well. The macula densa are just those cells that are responsible for detecting sodium in the distal convoluted tubule, and they say, hey, if there's too little, then they want to go ahead and activate the system as well, right? And so, again, decreased renal perfusion, you get more renin release. You get decreased salt or chloride, it's going to stimulate renin release. You have increased sympathetic nervous system activity, you're going to get more renin release, right? So overall, these things here all work together. And again, patients may have more so of one than the other, but they all work together to get more renin being released there. And more renin means more angiotensin 2, right? The angiotensin 2 itself is a vasoconstrictor. You're going to see more aldosterone secretion. So we talked about what that does already. It will cause renal vasoconstriction. So going back to our picture we were talking about before, if you go back to over here with the afferent arterioles coming into the glomerulus, the efferent arterioles, you actually are going to find the angiotensin 2. If I could control my computer correctly. What we're going to find is that angiotensin 2 is going to be a potent vasoconstrictor here at the efferent arterioles, okay? Ang2. Marvel at my art. So angiotensin 2 causes strong vasoconstrictive effects here. What does that do to filtration? Well, if you pinch off the hose on this end, it's going to increase back pressure here in the glomerulus, and that's going to cause decreases or increases in GFR, I should say. Okay. So again, I probably should like clarify this picture here a little bit. NSAIDs are going to block this, right? It's going to decrease this vasoconstrictive effect here. I'm sorry, actually, I'm confused here. No, they do cause constriction there, but point being is that with angiotensin 2, it causes direct vasoconstriction of these vessels here. So that is important for a lot of patients to keep their filtration up, because if they lose this pressure here, then they lose pressure in the glomerulus and filtration is diminished. So that's going to be an important side effect we're going to see a little bit in patients in terms of renal dysfunction you can see with the drugs. Okay, so just keep that in mind. Anyway, so we'll see that angiotensin 2 also does inhibit renin release to some degree. It's part of that negative feedback loop. And we're going to see increased sympathetic nervous system activity as well as a result of its use. We'll also end up seeing some other things, like it increases norepinephrine release. Norepinephrine is a catecholamine that causes increased blood pressure, heart rate, and it will stimulate thirst, right? Because it actually stimulates ADH secretion centrally. ADH, antidiuretic hormone, makes you want to drink water and eat salty stuff, right? It makes you want some Gatorade really bad because, man, the Gatorade's got some good salt in it, right? And it can also, and this is, I cannot stress this one enough, is responsible for remodeling in the heart, right? It can cause cell tissue hypertrophy and cardiac remodeling after MI. This is why these drugs are absolutely critical to use in patients for post-MI or the CHF, because they will prevent remodeling of the ventricle. What happens with the ventricles when they are overused or they get infarcted? They get stiff, they don't work very well, they don't fill very well. This helps to prevent that, and this is what's going to save patients over the long term. These are where the mortality benefits really come into play here for a lot of these patients, okay? Or part of the reason why they have mortality benefits, as we'll see. So, what happens if you have overactivity of the renin-angiotensin system? Well, you get hypertension. You can see CHF that can develop here as a result of left ventricular remodeling. You can see diabetic nephropathy. And you're like, why would you get diabetic nephropathy here? Well, again, if you have chronic overwork of the those glomerulus here, you can see if you have too much angiotensin 2, too much pressure here, you have all that glucose that's going to end up getting filtered, and it just causes shredding of the glomerulus, causes issues of that over time. So that's part of the reasons why these drugs are going to be important for patients with diabetes to prevent kidney damage from happening over time. So that'll be another important indication we'll see here in just a few moments. So, and again, I talked about the remodeling after MI here. So again, these drugs have significant effects on morbidity and mortality. A lot of patients should be on these medications. We'll talk about the different compelling indications here in a little bit. So what are the physiologic actions of ACE inhibition? What if I have a drug that blocks the activity of angiotensin converting enzyme? Well, I'm going to get less angiotensin 2 being formed. That's good. I'll get less renal vasoconstriction, which may be bad for some patients, as we'll see. I'll have less aldosterone being made. I'll have less sodium reabsorption. I'll have less sympathetic nervous system activity, so I'm going to have less norepinephrine being released overall, and I'll have decreased bradykinin metabolism. Okay, we're going to see all those actions, what that's going to do for us in just a few moments. So the ACE inhibitors themselves is the first class that will interact with this, is that they all have identical mechanisms of action. They all block angiotensin converting enzyme from working. The only difference is some have different half-lives, some undergo different metabolisms here. Most of them tend to be prodrugs. You'll see a lot of these are given orally, so that way the liver can convert them to their active forms. And then most of them get eliminated through the kidneys. One exception with fosinapril, but clinically that does not come up all that too frequently. You're going to see there's a lot of drugs in this category here because this was a blockbuster set of drugs when they first started coming out. It was a huge deal. They saw huge improvements in blood pressure, huge improvements in mortality. And so they said, well, I got to have mine too. So everyone produced one. That's why you see so many of them. Fortunately, they're very easy to determine which ones are ACE inhibitors because they all end with pril. Captopril, lisinopril, enalapril, benazepril, lisinopril, and trandopril. Oh, that was all? I'm just kidding. No, there's quinapril, ramipril, I actually put perindopril twice, didn't I? No, I didn't. Perindopril, moexapril. I actually did put it twice. Yep, you're right. So again, a lot of these drugs came out. There's a lot of Me Too drugs. There's not one that's particularly any better than the other, okay? Some of them have their specific uses. So for example, enalapril actually has an IV form. So I mentioned it's a prodrug normally. When these get converted, they go from enalapril or lisinopril into lisinoprilat or enalaprilat. That's how you know it's the active form. This one comes IV as the active form already, so I can use that for kind of quick management of blood pressure, which is pretty handy. But again, any of these are going to work very similar in terms of activity, in terms of side effects, and all of that. So again, you can kind of think about any of these interchangeably, at least for my purposes today. For test purposes, just be able to recognize that these are ACE inhibitors and then know what that means in terms of side effects and mechanism and all of that. So most of them are nice because they do require once daily dosing. And again, from a compliance standpoint, this is critical. You won't want things to be complicated. You don't want them to have a whole lot of dosing throughout the day because, again, it gets more complicated, decreases compliance. You may find some patients do require twice daily dosing. This is mainly if they're checking blood pressure throughout the day. And at the end of the day, they start to notice pressure rising. They could lose some effectiveness. And so that's one thing you'll see there. And then typically you're going to find that you don't need like mega doses for these drugs, so they tend to flatten out in terms of their efficacy. There's a definite plateau there. And again, increasing doses any further is just going to cause more side effects. So for the most part, there's a pretty standard range you'll see for these drugs to use, and you don't really need to go beyond that. What do we use these for? Well, for hypertension. These are going to be good for a lot of patients. A lot of patients are going to have a compelling indication to require this. So you may not be using the ACE inhibitor for hypertension specifically, but you may be using it for something else. But this also has the benefit of helping out with their hypertension, right? So overall, you're going to get less decrease in your TPR, your total peripheral resistance, because the vessels are going to be dilated more because they're not having angiotensin 2 squeezing down on them. And then overall, we're going to get less left ventricular hypertrophy because you have less pressure, right? Remember, why does the left ventricle get so hypertrophy for these patients? Well, because their blood pressure is high and they have so much afterload for the heart to press against, right? So much pressure it has to overcome in order to get that blood flowing. And again, any muscle, if you overuse it, it's going to get bigger. If you use it too much, it's going to hypertrophy. So by decreasing afterload, you're able to decrease that pressure, and then the ventricle can pump more easily, right? Kind of like taking some weights off of the bar makes it easier to lift, and that's good for your ventricle, right? Ventricles are meant for marathons, they're not meant for quick sprints. It's also preferred in diabetes because it's going to be kidney protective, right? Because again, if you look back at our picture here, by getting rid of angiotensin 2, you're going to have a relaxant effect here on the vessel, and this is going to lead to overall less pressures. You're going to see that overall it's going to lead to less wear and tear over time, and so this is really good for prevention of diabetic nephropathy. Now again, it's not going to reverse any damage done to the kidneys over time, but it will at least hopefully slow it down and prevent it from getting any worse, hopefully, if you can. So we talked about this being used also for left ventricular dysfunction. So this is basically for patients with CHF. We're going to find, and again, what's usually a preceding cause for CHF? Well, it's usually MI in a lot of cases here. So what we see is that by using ACE inhibitors, we can decrease left ventricular remodeling and hypertrophy. You're decreasing afterload, as I mentioned, which is great. We get some decreases in preload and some degree of increase in cardiac output, but this is less of an effect than you'll see on the afterload portion of it. And then this is the big one. You'll see prevention or delay of progression of CHF. You keep the ventricle healthier for longer if you can introduce this early, and you see less incidence of MI. Okay, hospitalizations. So anyone with LV dysfunction should be given an ACE inhibitor unless otherwise contraindicated. We'll talk about what those contraindications are in a few moments. Okay. Again, we use these post-MI because they help to prevent remodeling and they decrease overall mortality. So if you see a patient coming in for a STEMI, for instance, there's going to be a set of drugs they need to be on by the time they leave that hospital. They have to be on a beta blocker. They have to be on an ACE inhibitor. They have to be on aspirin. All these things here because we know they improve mortality. And again, insurance doesn't want to pay you as a hospital if you didn't send your patient on the right meds and they come back with another heart attack, right? as I mentioned, diabetic nephropathy, overall you're decreasing glomerular, that's hard to say sometimes, pressure and decreasing remodeling there. As I mentioned, it can delay or prevent progression of disease, although it will not slow it down. Okay. And again, really anyone with significant renal issues, they may see some slowed progression of disease for them as well. So it could be a big benefit for those patients. Okay. Now, what are the side effects? Again, these medications are not all sunshines and lollipops. There are some downsides to them. Dry cough can be seen in a healthy number of patients here, right? 5 to 15%. This is due to bradykinin buildup. Now, we said bradykinin actually it might be useful because if you inhibit its breakdown, it has a vasodilator effect, which can be good for blood pressure. But you increase the bradykinin can actually lead to accumulation of something called substance P in the lungs, and that can lead to this chronic dry cough. And for the patient, they may not even notice it, but for some, like their partners who may be in bed with them, they may want to kick them out of the house, right? So, and again, it can be seen anywhere from a week to 6 months after the fact, and it may not go away with chronic use. And so it's not related to one agent or another. It's not related to dose. And you tend to see it a little bit more frequently in women, although the only people I've ever heard of complaining about it are men. So I don't know, that's just anecdotal. You know, it's not dangerous necessarily. It's just annoying. And so this may cause discontinuation in a lot of patients. Okay. But there'll be another set of drugs we can use here as an alternative. Hyperkalemia, right? Because it is reducing aldosterone activity, you will increase potassium levels. So this is where you got to be careful. If I start mixing something like lisinopril plus something like, for instance, you know, spironolactone, you can end up seeing hyperkalemia develop here, right? However, what if I was to mix something like ramipril plus HCTZ? They tend to offset one another. One decreases potassium levels, one increases it, right? So again, you got to look at the drugs you're using to make sure you're not going to be skewing things one way or the other. You want to keep them in that nice range there. 3.5 to 5 is where you want the potassium to be. You got to be careful with those patients. If you go too high, you see arrhythmias. Too low, also arrhythmias and some other issues, right? Other things too, you're going to find that you can't see some hypotension associated with this. This is more commonly if you're using it in elderly patients, or if they are, you know, if they're like CHF and things like that, or if they're on other multiple antihypertensive drugs. So typically this is seen with like a first dose kind of thing here. So just have them be careful, maybe take them at nighttime. So that way they can kind of sleep through some of the initial side effects and they're kind of used to it by the time they get up in the morning. That can be sometimes beneficial. Now, the renal function impairment is important here because if you use this in a patient who is really dependent on this angiotensin II, they have to have this pressure around in order to make filtration actually work. If you lose that all of a sudden, if I just all of a sudden introduce an ACE inhibitor and I get rid of this, these vessels are going to dilate, and that's going to decrease pressure at the glomerulus, and GFR is going to go down pretty significantly. This is not an issue for healthy patients who don't require a ton of angiotensin II to get their kidneys to work. But if they have existing kidney disease and you get rid of that angiotensin II activity, this can lead to an acute, dramatic drop in their kidney function. You say, well, wait a second. A second ago, you're talking about it being kidney protective. It is. Because overall, less pressure here is going to be a good thing for those patients because it leads to less wear and tear. But acutely, if you use a big dose in these patients that require angiotensin II, you're going to cause an acute decrease in kidney function, can lead to some problems. Acute kidney failure in some cases. So instead, what you do in the general mantra for elderly patients or patients who are particularly sensitive to these drugs is start low and go slow, right? These patients are frequently not in a state where you have to go full blast right away. This is a chronic disease state you're treating here most of the time, so you got time to work with them, okay? It's okay if it takes a couple days to weeks to get them up to the full dose. But again, you got to be careful when you're going with those patients who require that angiotensin II pretty significantly. Okay. So use cautiously, go low. You start low and go slow. That's the general mantra here. So what are some other issues we can run into? Things like angioedema. This is particularly unique to the ACE inhibitors here. Pretty rare for the most part. Some of it's thought to be due to bradykinin accumulation as well. But as opposed to a traditional sort of anaphylaxis reaction, which is more IgE mediated, this is a little different. And so they kind of look similar though, because you know, patients with angioedema, typically they have a lot of swelling of the upper airway. They don't really get the same like hypotension and itching and things like that like you would see with a typical anaphylactic reaction because the mechanism is a little different. But again, here you can see for some patients, they could be on this for years potentially and have it develop. Some people are on it for a week and they develop it. Just depends. But basically, they have this rapid swelling of the nose, the throat, the mouth, the lips. Have you ever seen someone's tongue just completely protruding out of their mouth? That could be related to angioedema related to an ACE inhibitor, for instance. And so that's really bad because what happens when all that stuff starts to swell up? Well, your airway may be occluded. Sometimes you have to use something like a nasotracheal tube because you can't even get an endotracheal tube in because everything is so swollen. I've seen some cases where they actually had to go through with fiber optic cables and actually go through the nose in order to get an airway established. Otherwise, you have to do a cricothyrotomy, and that's never a good thing to do for the patient. So that's something you want to be careful of. If they have angioedema to one ACE inhibitor, you do not want to put them on another ACE inhibitor because they can have cross-reactivity there, okay? Because it's mainly due to the buildup of bradykinin. You also do not want to give this to pregnant patients. Fetal morbidity, mortality, these are going to be category X for those patients. We'll talk about pregnancy categories next semester, but category X is no go. You don't want to use it. Just like with statins, you don't want to use that in pregnant patients. You don't want to use these either, okay? We'll talk about pregnancy later and talk about which drugs are preferred for them. And then you're going to see that NSAIDs can actually decrease ACE inhibitor activities, and this has to do with some of the relaxation effects of the prostaglandins, kind of like what we were talking about on the glomerulus earlier there. Okay, so what would happen if you wanted to use, if you had a patient who had cough related to their ACE inhibitor, if they, had a history of angioedema, you got to have something else you can use instead. And so this is where angiotensin receptor blockers come into play. And so instead of blocking the production of angiotensin 2, you just block the receptor itself, right? Because angiotensin, or ACE is not the only way to actually produce angiotensin 2. There's a few other enzymatic pathways. And so by blocking the receptor itself, you can get some additional benefit there. Now, AT1 is the main receptor we're going to see in adult patients. AT2 is actually what's developed during fetuses, which is why they're so teratogenic. And so again, you're going to see anything that messes with ACE or the angiotensin system in developing fetuses is a no-go. You don't want to use them. But angiotensin 1 receptor is what we're mainly going to focus on here. And again, by blocking these receptors, you're going to block the most of the important parts of angiotensin 2. You're blocking the vasoconstriction, blocking aldosterone, cell proliferation, all of that. What you do bypass, though, is you don't have any effect on bradykinin. So ACE is still available to break down bradykinin. So you lose the cough, and in a lot of cases, you mitigate the risk for angioedema. So that's the benefit of using an ARB for those patients there. Now, you're like, well, why not just put every patient on an ARB? There are some downsides because for some patients, that extra bradykinin is useful. It's useful as a vasodilator. So, it just depends on the patient what they're most sensitive to. I have a cousin who was on an ACE inhibitor. He had a horrible cough. His wife almost kicked him out of the house. So he switched over to an ARB, and everything was fine, right? So able to get his blood pressure under control. So anyway, looking at this, you're going to find that they have very similar actions to the ACE inhibitors, right? For the most part, they can be used interchangeably. Okay, one for the other is totally fine because they will get very similar actions systemically speaking. The only real big differences here are that ARBs are going to be better at reducing the effects of angiotensin 2 at the receptors themselves because overall, ACE is not the only way to produce angiotensin 2, so that makes some sense. Clinically, though, some of these things are not super important here. The big ones to note is you're going to find that ARBs don't break down bradykinin, which is a disadvantage from a blood pressure standpoint. And then you're going to find from an elimination standpoint, most ACE inhibitors are renally eliminated, whereas the ARBs tend to be both renal and biliary excretion. So a little bit of difference there in terms of kinetics. Now, how do you tell an ARB? Well, they all end with sartan. So you see candesartan, olmesartan, losartan, azilsartan, eprosartan, irbesartan, telmisartan, and valsartan. Again, these are a bunch of Me Too drugs because what they found that, wow, this is a really big blockbuster. We can make a lot of money here. Let's go ahead and put ours out on the market. They'll have very similar activities. You can use one for the other. And in fact, this is a big one that came up recently where we had drugs like valsartan actually had certain carcinogens found in them. And we had to switch a whole bunch of patients over to an alternative agent here. So that was a big hassle for both, primary care offices along with pharmacies where they had to actually go through and come up with alternatives for their patients because they had to get them off valsartan because it was removed or at least recalled for the time and put them onto something else. So what do we use these for? Nice thing here, same indications as ACE inhibitors. No huge differences there. They still work for hypertension, for LV dysfunction. They still work for diabetic nephropathies. You can keep their ideas and the same things in mind as the ACE inhibitors. They still cause hyperkalemia. You can still see hypotension. They still can cause renal dysfunction. You still don't want to give them during pregnancy. So again, all of this is very synonymous with one another, but you do want to know the differences. You know the differences in cough, and you want to know the differences in risk for angioedema. Those are the big things you want to know as being different between the other two, okay? Again, does not cause cough and lower incidence of angioedema. For someone who had a history of ACE inhibitor-induced angioedema, you may be able to switch over to an ARB if it is clinically really indicated. But I would be very careful. Make sure you're watching them. Make sure that you know, they have clear instructions on what to do if angioedema starts to develop again. But the risk is relatively low. Okay. All right. So let me see if there's any questions there. Over. So someone said ACE, steep dose response at low doses, higher doses, flatter dose response. Question mark, question mark. I'm assuming you're asking what that really means. That basically means if you were to look at a graph of their effectiveness, space here. If you were to look at a graph of their efficacy, right here, it'd be kind of annoying. I don't know if there's a better way to do this. That did not work. I'm just going to do a new one. I don't really need those other stuff anymore. Anyway, if we're going to look at a graph of the efficacy of the medications here, what would we see? Basically, what this means is if you were dosing a medication like an ACE inhibitor, I apologize for my poor skills here. I'm not very good at this, obviously. So if I was dosing something like an ACE inhibitor, what I would normally see is that, you know, at baseline, if you have no dose here, then of course it's going to be no effect whatsoever. And as I start to give the dose, start to increase, you're going to see there's a pretty steep curve here in terms of increased efficacy of the drug. And then at a certain point, you're going to get basically a flat dose response curve, right? So again, this is the normal dosing range you would be at. If I kept increasing the dose here even further, I really wouldn't see any additional benefit from the drug. So there's a plateau effect that occurs here, where even if I keep increasing the dose of the drug, I get no additional benefits. That's why you get a very tight sort of dosing range there. You may only give between, say, 5 milligrams to 20 milligrams of an ACE inhibitor, and that's really the only effective range. I can give 40, but it's not going to be any more effective there. So that's kind of what that's referring to. That's probably by far my worst art that I've drawn yet in this class, so you can just erase that and get rid of it. Anywho. So we got some more time here, so let's start going through our calcium channel blockers, another important class here. There's a lot of different types of calcium channels in the body, but we're going to see here the L type are going to be most important for our purposes here. There are going to be two big delineations of calcium channel blockers in the body. We're going to have dihydropyridines, and then we're going to have the non-dihydropyridines. You don't have to memorize these drug names, the chemical classification names here. Just know that we have dihydropyridines or DHPs, and then we have our non-dihydropyridines. They're going to have very different actions here in the body, but they all work through the same L-type calcium channels. So where do we have these in terms of the cardiovascular function? We're going to see they reside on the vascular smooth muscle, which is going to be important for causing vasoconstriction or dilation. They also are present on the cardiac myocytes and then on the cardiac nodal tissue, meaning SA and AV node. Okay. So looking at the heart itself, we can see that calcium plays a big role in both affecting the SA node and the AV node, which are main pacemaker cells in the heart, right? The SA node is setting the main beat for the heart based on a number of things, like, you know, the effect of the sympathetic nervous system and the parasympathetic nervous system. But you see calcium has a big role to play here, as well, as we'll see in a few moments. But also the ventricular myocytes also depend on calcium as well. That's what causes that little plateau effect here, if you actually look at the action potential. And so if we block that, what's going to be interesting to see is we can actually block them at the pacemaker cells to cause decreased heart rate. There can be negative chronotropy, and they can block calcium in the actual muscle itself to decrease the contractility of the heart, meaning decrease inotropy. Inotropy is how strongly you're contracting. The speed or the rate of the heart is going to be the chronotropy. So we're going to see that some of these are actually going to be negative chronotropes and negative inotropes, which may be useful for some patients there. Okay. What you can see is if you're looking at something like the SA and the AV node, notice here how these cells have kind of leaky sodium inward currents, and then you have the calcium influx that is really important for causing the actual heartbeat to occur. If I block calcium here, you're going to slow down the heart rate. And similar here, if I block calcium from flowing into the cardiac cell, I'm actually going to decrease contractility as well, as I'll show you in just a moment here. Normally what happens in a cardiac cell, when you have calcium influxing during the action potential, this causes calcium to be released from the sarcoplasmic reticulum, and that's what causes the actual actin and myosin to bind together to cause the heart to squeeze, right? If I block calcium from coming into the cell, as a calcium channel blocker might do, I'm going to then cause decreased release of calcium from the sarcoplasmic reticulum, and I get less squeeze. Okay, that may be good for some patients, that may be bad for other patients, as we'll see here. So these drugs can be a double-edged sword to some degree. Now, what about the vascular smooth muscle? Well, if I block calcium from coming into the cell here, again, you can see the sarcoplasmic reticulum is going to have less calcium being released as well, and that leads to less, again, binding here between actin and myosin. You're going to see less squeeze. This is what's going to cause the vascular smooth muscle relaxation that we can see with some of the drugs here, okay? So one of the big distinctions you're going to want to make between your different calcium channel blockers is, does it work mainly on the heart and to some degree on the blood vessels, or does it mainly just work on the blood vessels? Because their actions are going to be quite different depending on where they're working at, based on kind of what we've seen here already. So looking at the effects of calcium channel blockers on the veins, we're going to see that typically these are not great at reducing venous tone. They really don't do a whole lot of good job there, but they do have good effects on the arterial tone, meaning they can decrease squeeze on the arteries, which means they decrease afterload, but they don't have a big effect on preload. Okay, so if you had a patient who's volume overloaded due to CHF, this doesn't really do a whole lot of good for them, but it does decrease the afterload, which decreases the amount of pressure the ventricle is having to pump against, which can be good if they're hypertensive. Looking at the effects on the myocytes here, we're going to see that looking at myocardial cells, they depend on that calcium coming in from the outside in order to help release calcium from the sarcoplasmic reticulum, and by blocking that, you're going to be seeing that they get less squeeze on the ventricles, right? You're going to get less squeeze in the actual cardiac muscle itself. And then with the arterial blood vessels, you see they are also dependent on exogenous calcium, and so if you're blocking those as well, they're going to cause relaxation of that smooth muscle. Arteries are probably going to be a little more sensitive to the action than the myocardial cells, but we'll see depending on the drug we're talking about. There's more of an emphasis on the heart actions versus on the blood vessel actions, as we'll see. And I'll make that pretty clear for you coming up here. Okay. So, and then look at the nodal effects, you can see that basically, if you're making the delineation here, DHP stands for dihydropyridine, as I mentioned. There's going to be one class of drugs. They really have no effect directly on the heart. They have no direct effects on the heart. They mainly just dilate the blood vessels. The non-DHPs, and I'll show you the two drugs that fit in that category, are going to be good for both affecting the blood vessels to some degree, but they mainly work on the heart to slow down that nodal conduction, so slow down heart rate, and then they also decrease the contractility of the heart as well. Those are the two big distinctions, and there's graphs I'll show you here in just a minute to make that very, very clear, okay? What do we use our calcium channel blockers for? We can use them for things like angina. We can use them for hypertension. We can use them for supraventricular arrhythmias, which makes sense because they work on the SA and the AV node, I should say. Diastolic heart failure, cerebral ischemia, and then in some cases, migraine prophylaxis. Some of these things we're going to talk more specifically about when we get to them. So for instance, next semester, I'll talk about migraines and prophylaxis there, but we're going to mainly focus on the cardiovascular effects of these drugs right now. So here's that table I mentioned. This makes it pretty clear how these drugs are working. I'll show you the list of dihydropyridines in a few minutes here, but here is diltiazem and verapamil. These are your two non-dihydropyridines, okay? All the other drugs are going to fit into the dihydropyridine category. It's really important you know the distinction between what actions the non-DHPs are going to have versus the DHPs, okay? I guarantee there's going to be questions on the test that's going to include that, but also for your purposes for knowing for clinical practice, you got to know the difference in how these drugs are used. If you try using a dihydropyridine for supraventricular tachycardia, it's not going to do anything. In fact, it might worsen it. You know, if you're just looking for a patient who has CHF, you want to help their blood pressure, giving them a diltiazem could end them up in the hospital. So again, knowing the distinction here is important. I'm going to talk about this extensively, okay? So looking at this, diltiazem and verapamil, they have okay effects on vasodilation, but they're not going to be the strongest ones here, okay? Again, do I care if you know if it's 2+, 3+? No. Just in general, what effects you're going to see. They do have effects on vasodilation, but it's less so than you're going to see with the DHPs. Their biggest effects are going to be on suppressing contractility and then suppressing SA and AV node function. They're going to slow down heart rate, and you're going to slow down contractility, okay? On the other hand, dihydropyridines are really going to have minimal to no effect on automaticity and no effect on contractility, okay? But they have big effects on vasodilation. So these are going to be much better for something like hypertension specifically, and these are going to be better for things like decreased contractility and heart rate, right? We're going to see where we use these differently based on their indications and things like that. So let's talk about diltiazem first. Fortunately, and I don't know why I have them separated here in the slides, I probably wasn't thinking straight, but diltiazem and verapamil, you can kind of think about them pretty synonymously in terms of their actions here. So what do we use these drugs for? First off, we do have IV and PO forms that are available. I'm not going to quiz you on that specifically, but it's good to know we have IV forms that we can use for arrhythmias or blood pressure control potentially. And what do we use them for? For things like angina, hypertension, and supraventricular tachycardias. This means that AFib, aflutter, PSVT, things like that. These are all good indications for diltiazem. These are probably not going to be first line for hypertension, as we'll see here in a little bit later, but they can still be useful add-on agents if you need something to help slow down the heart and treat the blood pressure at the same time. I have a whole section talking about angina specifically. Now, side effects. These drugs are chock full of side effects, which is why they frequently are not going to be first-line drugs for a lot of patients because of all these issues that come up here. So one thing you're going to see, based on their relaxation of smooth muscle, you're going to see peripheral vasodilation, headache, flushing, hypotension, peripheral edema. This is a big one for these class of drugs here, and dizziness. Makes sense. Due to the negative inotropic effects, you can end up seeing heart block. You can see bradycardia. You can see worsening of CHF because you're decreasing contractility of the left ventricle, and they are required to have that contractility. Otherwise, they can go into an exacerbation or even pulmonary edema in some cases there. Due to relaxation of smooth muscle in the GI tract, you can have nausea and vomiting. You can lower the squeezing tone on the lower esophageal sphincter, which can lead to reflux potentially. You can lead to constipation as well. That's a very common thing you'll see with the calcium channel blockers. You may see some bumps in LFTs. CNS effects, as I mentioned, this is pretty common for a lot of antihypertensive drugs, but fatigue, drowsiness, dizziness, all of that is fairly common just because you're decreasing blood flow to the brain to some degree, especially for patients who are not used to those effects there. Can see some gynecomastia and sexual dysfunction, gingival hyperplasia, and some skin reactions. A lot of side effects, right? And this is why we don't use these typically as first line, but where they're useful, they can be very handy, right? Someone's asking a question here. So can you describe in layman's terms what an NSAID plus loop drug interaction is? Can you also re-explain what a digitalis toxicity is? Or I'm going to talk about digoxin later, so we'll get to that when we get later on. So can I describe in layman's terms what an NSAID plus loop drug interaction is? Well, you guys aren't lay people anymore. You should be medical experts, right? No. Loop diuretics. All right, let me go back to the picture here. Normally what you expect to see is that loop diuretics cause increased water excretion from the kidneys, right? Cause you to hold on to less water. Well, that is dependent on having filtration happening here. If I don't have any filtration happening, there's no water coming in for the loops to even work on. And that can be affected by the NSAIDs. If I don't have prostaglandins here to open up the afferent arteriole, NSAIDs are going to constrict down on this vessel, and thus I'm going to get no flow coming through. I'm going to get less flow, right? It's all relative. Less flow here means less filtration, means less water coming through, means your loops are not going to be as effective. Okay? Hopefully that makes some sense. If not, let me know. So a lot of issues here. So in terms of contraindications, what you'd expect to see are things like advanced heart block, because obviously it's going to worsen that, hypotension, and then some relative ones you want to watch out for include things like heart failure, liver disease, and GERD, right? Because all those things can be exacerbated by the addition of diltiazem. Now, the other thing to note with the non-DHPs, this will apply both to diltiazem and verapamil, is that they are both substrates of 3A4 and they both inhibit 3A4. For whatever reason, it's always trips up students, but just because something is an inhibitor doesn't mean it can't also be metabolized by that same enzyme, and frequently that's going to be the case here. But diltiazem and verapamil specifically are 3A4 inhibitors, which means they can affect many of your statins like we talked about last week. They can affect a host of other drugs, which we'll get into later on, probably next semester. So if a drug is metabolized by 3A4, diltiazem or verapamil is going to increase those levels as the enzyme itself is being inhibited. It can also affect this protein called P-glycoprotein, which can increase levels as well. This is something that's responsible for spitting drugs back out into the GI tract. And if this is inhibited, along with CYP3A4 being inhibited, it can have big increases in levels of most of these drugs here, right? Again, if I haven't talked about the drug specifically, I'm not going to quiz you on it unless I'll tell you on the test that says, hey, this is a CYP3A4 or PGP substrate. But if we have talked about the drug, like by the time the test rolls around, I will have talked about propranolol. That is fair game. or the statins are certainly fair game, right? And then in terms of pharmacodynamic interactions, this makes sense. If it's being used with other antihypertensives, well, your risk for hypotension can go up. If you're on other drugs that can decrease heart rate or increase AV block, these are going to be synergistic with one another. We'll talk about beta blockers, digoxin, amiodarone, all a little bit later on. Just know that anything that slows down heart rate and can cause AV block, this can be worse, and this is why you don't want to use them in addition to things like diltiazem and verapamil. Now, as I mentioned, diltiazem is also a substrate of CYP3A4, which means that if I have other inhibitors on board, that this can increase the half-life of this drug as well, right? So not only is it a 3 and 4 inhibitor in and of itself, but it can also be affected by other CYP3A4 inhibitors because it is metabolized by CYP3A4. So again, it sounds complicated, but it's pretty straightforward when you think about it. It is both an inhibitor and a substrate. And so other things can come along and affect it too, okay? In terms of pharmacodynamic effects, it's going to be the same as what we saw last slide there. And now again, you're going to see with verapamil, it's all the same indications. Again, all the same activity here, maybe a little bit better vasodilation, more effects on hypertension, but for the most part, we use these interchangeably. It really just depends on whatever the hospital wants to put on their formulary or whatever the provider wants to prescribe on an outpatient basis there. All the side effects are going to be exactly the same, no differences there. Same contraindications and same drug interactions here. Because again, it's still a 3A4 inhibitor, right? Again, I don't know why I separate the slides out, but I always forget to put them back together the next year. But these are important to make sure that you see that these are both inhibitors and substrates of the enzyme, okay? Okay, so now what I want to get into is the actual dihydropyridines. This is the, again, these are going to be very different from verapamil and diltiazem because they are going to be just working on the blood vessels. They don't really have any direct effect on the heart. They're going to have some indirect effects on the heart, as we'll see here in a few moments, though. And so this includes things like amlodipine, nifedipine, and nicardipine. They have fulodipine, isradipine, nisoldipine, and then nimodipine. Obviously, you can tell it's a dihydropyridine because it ends with dipine at the end of the name there, okay? Now, again, we're going to use these for a lot of things. Most of them have some overlap, so I don't really care that you memorize specifically which ones are for angina and hypertension versus just hypertension. They're going to be used interchangeably for the most part, right? But you can use them for things like angina, hypertension. Those are the main indications you're going to see there. Nimodipine is kind of interesting because it can actually be utilized to help prevent cerebral vasospasm in patients who have subarachnoid hemorrhage. So that one's kind of pretty unique for nimodipine there. Typically, these are going to be PO only, so these are going to be for use more chronic, kind of outpatient sort of basis is here for the most part. And again, you notice they're working on vasodilation, but they don't do anything in terms of contractility or nodal conduction. No effects there for the most part. Now, what are you going to see here? The peripheral vasodilatory effects are going to be even stronger here than what you saw with the non-dihydropyridines. So peripheral edema, you can see dyspnea, wheezing as a result of that. You can end up seeing, as a result of pulmonary edema to some degree, and you get a rebound tachycardia. That doesn't make sense to a lot of students. But what happens if you decrease blood pressure? Well, your body responds by increasing cardiac output. How do you get cardiac output up? You increase the heart rate is usually the most common thing, right? You think about cardiac output as a result of your heart rate and stroke volume. So if I increase heart rate, that's going to increase my cardiac output, okay? So again, a handy way to remember that if SVR goes down, systemic vascular resistance goes down, to compensate, cardiac output has to go up, and that is most often done with heart rate. So that's why if you have someone who came in who was on a verapamil, they would come in and they may have bradycardia hypotension. If someone who comes in on a DHP like amlodipine, they may present with hypotension tachycardia. And you got to understand the difference of why that is, and it makes sense if you know where they're working specifically. You know, the non-DHPs are working on the heart and on the blood vessels. DHPs are specifically working on the vessels. Why do they have an indirect effect on the heart? Well, because they're dilating all those vessels and cardiac output has to catch up. And the best way to do that is with heart rate, okay? We're still going to see issues of GI effects, mainly due to relaxing that lower esophageal sphincter. So GERD is going to be worse in here. Still see CNS effects due to relative hypotension, gynecomastia, gingival hyperplasia. Those are all things to note there. Good oral hygiene is important for these drugs. Make sure they're brushing their teeth, consistently. Otherwise, that can help keep that gingival overgrowth kind of under control there. Other contraindications for these, which are a little different than some of the other drugs we mentioned so far, the severe aortic stenosis. This can be a problem because, again, they rely on that pressure in order to compensate for the aortic stenosis. So that can be contraindication there because it can cause decreased perfusion pretty significantly. And then if they have unstable angina or recent MI, this is specifically with immediate release formulations. Now, you saw before we actually use this to treat angina, and I'll talk about how we use those in a later PowerPoint. But the big thing here is if you use an immediate release preparation, they typically cause big drops in pressure, and that can lead to decreased perfusion of the heart, which can exacerbate that MI. So that's why we want to be cautious there. So the big things here are that whereas the non-DHPs were inhibitors and substrates of CYP3A4, the DHPs are not inhibitors. They're just substrates for CYP3A4, which means that other drugs can come along, can inhibit that enzyme, and you'll increase the half-life of amlodipine. You know, other drugs that induce 3A4, and that will cause a decrease in the half-life of amlodipine, right? So again, know those interactions and how they work. We'll see pharmacodynamic interactions. Typically, other antihypertensives are going to be interacting here. We're going to get into those specifics when we get into those drugs later on. Probably not this week. And again, know that if another 3A4 inhibitor is on board, you're going to increase the half-life of the DHPs, okay? All right. So that's it for this section. I got through most of what I wanted to get through, which is good and keeping me on track. Let's look at the sticky board over here. Got a couple questions. Someone said, when you say we need to know is K plus or is potassium is increased or decreased, do you mean intracellularly, extracellularly? Can you give me an example of what you mean? I'm talking about blood levels of potassium. So if I give you, if your potassium sitting at 4, and I give someone a loop diuretic, you need to know that's going to go down because you're going to be excreting more potassium. Total body levels of potassium are going to go down, right? Because you're excreting it, so it's going to be some shift between intra and extracellular concentrations there. If I give you an ACE inhibitor, your potassium is going to go up. The serum potassium you're measuring on a BMP, that's what's going to be shifting there, okay? If I give you an ACE inhibitor plus a diuretic, maybe they're balanced. Maybe they're offset one another because one increases, one decreases. You have to know what those different interactions are going to be. Because if I give you an ACE inhibitor plus spironolactone, that's going to doubly increase your potassium. So you've got to watch for that stuff. This is why I have to be very careful with these drugs. Very easy to kill someone if you're not careful and give them hyperkalemia. Okay. Someone said non-DHPs being an inhibitor and substrate for CYP3A4 means it has a long half-life in turn. It depends on the drug, right? So again, just because it does not necessarily inhibit its own metabolism, the drug's half-life is what the half-life is based off of the fact that it is somewhat of an inhibitor. So you can look that up. Some of these drugs are given via continuous drips to control heart rate. Sometimes you will see controlled release preparation. So if you ever see like Callan SR, that's verapamil sustained release. I see diltiazem CR, that's diltiazem controlled release. Again, those are long-acting formulations of the drug. So no, that does not mean they themselves have a long half-life necessarily. That's a good question. What other questions do you guys have? And again, always feel free to talk in the chat. That makes it more interesting for me because I'm always looking at that. And, just don't feel free to, or don't feel bad about asking questions. It makes it more interesting for everyone because I guarantee if you have a flawed understanding of something, everyone else probably has the same flawed understanding. It's good to uncover that. I'm not going to make anyone feel bad about not knowing something, right? You're students, you're here to learn. I expect you to not know anything, and that's why I build everyone up, right? So don't feel bad about asking questions there. It just makes it more interesting. Otherwise, I just talk to myself for 2 hours, and that's no fun, right? Not for me, and certainly not for you guys. But that's it for this week. If you have any questions, feel free to either email me or pop them up on the board for next week or whatever else. And otherwise, you guys have a great weekend, and I will see you next week. Down here for a minute or two, just see if anyone pops up with a question. Yeah, thank you for joining me. I appreciate it. No questions, so I'm going to go ahead and end the stream, but I will see you guys next week.